Welcome to The Explainer. Today, we're tackling a field where every single detail matters, managing perinatal infections. Given the stakes for both mother and child, a solid grasp of the evidence-based protocols isn't just helpful, it's absolutely essential.
This statement right here really captures the heart of it all. The vulnerability is real, and it means every choice we make, from the antibiotic we pick to how long the treatment lasts, carries an immense amount of weight.
So in this explainer, we're going to break down the management for three key conditions: urinary tract infections, postpartum mastitis, and Group B Streptococcus. We'll get into identifying the pathogens, the specific treatment protocols, and of course, the complications you need to watch out for.
Okay, let's start with urinary tract infections. And right off the bat, it's so important to realize that treating a UTI in a pregnant patient is a whole different ballgame compared to a non-pregnant patient. The therapeutic considerations are unique.
So a perinatal UTI really exists on a spectrum. On one end, you've got uncomplicated cystitis. That's your basic bladder infection. But on the other, more severe end, you have pyelonephritis, which is a kidney infection, and that can get serious fast, requiring a much more aggressive approach.
And you can see how different that approach is right here in the protocols. For that straightforward cystitis, the first-line choice is an oral agent, nitrofurantoin, for just 5 days. But for pyelonephritis, the standard of care is completely different. It means hospitalization and IV therapy, usually with something like cefotaxime, a third-gen cephalosporin, for a good 10 to 14 days.
Now, beyond these main protocols, there are some really critical clinical caveats. First, a huge safety point. You've got to avoid nitrofurantoin near term, so within about 30 days of delivery. If you're dealing with severe sepsis from pyelonephritis, you should be considering a single dose of gentamicin to get on top of it. And finally, a note on asymptomatic bacteriuria. While we don't routinely screen for it, if you find it, you need to treat it just like you would cystitis.
And this brings us to a fundamental challenge that underlies every single prescription we write: antimicrobial resistance. Our treatment choices are never made in a vacuum. We always have to think about that bigger picture, about the need to protect these incredible drugs for the future.
All right, our second challenge takes us into the postpartum period. We're going to talk about mastitis, which is a really common and often incredibly painful condition for new mothers who are breastfeeding.
So, mastitis is, by definition, an inflammation of the mammary gland. And to manage it effectively, you have to know what you're targeting. The primary culprit, the pathogen we're usually up against, is Staphylococcus aureus.
And since we know that S. aureus is our main target, the first-line therapy is very specific: oral flucloxacillin. Now pay close attention to the dose here: a full 1,000 milligrams 4 times a day. And just as important is the duration. A full 2-week course is absolutely essential to knock it out completely and prevent it from coming back.
A really crucial part of management here is thinking about potential complications. While that flucloxacillin regimen is great for uncomplicated mastitis, if the infection progresses and forms an abscess, well then antibiotics alone just aren't going to cut it. At that point, surgical drainage becomes a necessary critical intervention.
Okay, on to our third and final challenge: Group B Streptococcus, or GBS. Now this one's a bit different. It's not really about treating an active infection in the mother. It's all about preventing a potentially devastating infection in the newborn.
So, the decision to give these preventative or prophylactic antibiotics during labor is driven by some very clear indications. If a woman has had a previous baby with invasive GBS disease, that's an absolute indication. Same goes if GBS is found in her urine during this pregnancy. And timing is everything here. For the antibiotics to be effective, they have to be given IV at least 4 hours before delivery.
The treatment algorithm itself is very straightforward. The gold standard, the #1 choice, is intravenous benzylpenicillin. But what if your patient has a penicillin allergy? Well, the indicated alternative is IV clindamycin. But, and this is a big but, that choice has to be guided by your local data on antimicrobial resistance.
Now, if despite all the prophylaxis, a neonatal infection is suspected, we have to move fast with what we call empiric therapy while we wait for culture results. For suspected early onset sepsis, that initial combo is benzylpenicillin plus an aminoglycoside. If meningitis is on the table, it shifts to amoxicillin and cefotaxime. And then, once GBS is actually confirmed as the cause of that meningitis, the definitive treatment is a long course of benzopenicillin.
All right, we've gone through all the principles. Now let's apply this knowledge and see how it works in practice. We're going to run through 3 quick clinical cases. Try to think through your answer before I reveal the rationale.
Okay, case number 1. You have a patient in her second trimester with a confirmed case of uncomplicated cystitis. What's the right first-line oral antibiotic to reach for?
The answer is nitrofurantoin. It's the established first-line agent for this exact scenario. Doxycycline is flat-out contraindicated, ciprofloxacin isn't a first-line choice, and gentamicin is an IV drug for severe disease. This really shows why it's so important to know not just what to use, but why the other options are wrong.
On to case 2. You've got postpartum mastitis, and this is key, there's no abscess present. What's the specific drug? And just as important, what's the duration of therapy?
And the correct answer is flucloxacillin for 2 weeks. This choice is all about targeting the most likely pathogen as Staph aureus, and that 2-week duration is the absolute standard of care. It's what's needed to prevent a relapse or a more serious complication.
And for our final case, we have a very high-risk scenario. A woman is in labor, and she has a history of a previous child who had invasive GBS disease. What is the required prophylaxis here?
The one and only correct answer is intravenous benzylpenicillin. That history is a strong, absolute indication for prophylaxis. It has to be given IV to work properly, and benzylpenicillin is the #1 agent. Oral antibiotics just aren't going to cut it in this situation.
And that brings us to our conclusion. You know, mastering these protocols is about more than just being a sharp clinician. It's about our fundamental duty as stewards of these incredibly valuable antimicrobial agents.
So this leaves us with a really critical question we all need to be thinking about. The protocols we've talked about today are based on the best data we have right now, but microbial evolution doesn't stop. As clinicians, as researchers, we have to stay vigilant, constantly reevaluating our strategies. We need to make sure we're not only treating today's patients effectively, but that we're also protecting our most vital medicines for tomorrow. Thanks for joining this explainer.